Good morning. Okay. No seats in, there's still seats in front. Okay. Okay. My topic for today, is on adverse events following immunization, surveillance in clinical practice. Before I show my next slide, who among you have actually reported an adverse event following immunization to the Department of Health? Thank you for reporting. Okay. Before I again proceed to the next slide, how many of you are willing to get the H1N1 vaccine we're about to distribute by this month? Are you sure? Let's see after this lecture. Bigla. Hindi, pinapa-ano ko lang sila. Kasi, okay. I don't know. Okay. So, we need safe and efficacious vaccine. But what is actually safe? Now, safe may be defined differently by most people, but for the Immunization Safety Committee of the Department of Health, we have to be very firm about safety of vaccines. Okay. Like all drugs, no vaccine is 100% safe. What is an adverse event following immunization? Okay, it's any medical incident that takes place after immunization. I remembered this was not due to vaccination when I was still at the National Center for Infectious Disease, and we conducted a mass prophylaxis using praziquantel for eliminating schistosomiasis, firstly in Mindanao. Because we were also watching out for adverse events following the mass prophylaxis using praziquantel, we would wait for reports of these adverse events. One of the adverse events apparently reported to us was pregnancy. I hope that will not be reported for vaccines. Okay. A vaccine reaction is caused by the vaccine's inherent properties. Now, let's look at the multidimensional components of adverse events with this slide. Okay. Okay. Really, the one at the target in the middle is the event attributed to the vaccine. All others, including the vaccine reaction, are events attributed to the immunization. Okay. So everything that occurs after an immunization will be labeled an adverse event. Okay. Now, we have to monitor the adverse events following immunization. We want to identify the urgent problems so that we can investigate and respond immediately. We want to detect signals for potential follow-up and research. And we want to estimate the rates of serious adverse events. We want to identify programmatic errors so we can correct them and create awareness of risk among health professionals. The last one, Dr. Gatchalian did an excellent job of describing the risks and informing the audience today of such risks. Now, for determining the magnitude of the adverse reactions, we use terms like very common, frequent or common, infrequent or uncommon, rare or very rare. To translate this, we have the numerical values assigned to each of the terms I have just described. So, for example, if the rates will be more than 1 or equal to 1 over 10, then, or more than 10%, that's relatively very common. Compare that to very rare, which will be less than 100%. Okay. Now, vaccine reactions can be categorized according to common minor reactions or rare more severe reactions. For surveillance, we are interested in background rates supported by evidence available in literature from studies from researchers as annotated by Dr. Gatchalian earlier. So, for example, for BCG, we expect that local reaction that involves pain, swelling, or redness to occur up to 95%. So these are the background rates. So for rare, more severe, we want to describe the particular reaction for each of the antigens or vaccine. And then we want also the temporal association between the immunization and the appearance of these rare or more severe reactions. So this is the timeline. So that if it's outside the timeline, then then it is unlikely that it was due to the vaccine. And of course, the rates per million doses. And this is the same in this table for the following vaccines. Okay. And the same for this table. Now, why do we want rates? We can use them to assess the extent of underreporting. For example, if we expect certain reactions to occur half of the time or per million doses, and the ones reported to us did not even reach 10%, then we know we are underreporting. In the Philippines, we are not reporting. Then we can use this to identify trends of concern. And there's a reason why it's like nosocomial infection. We are afraid. We are afraid to be responsible. We are afraid to be accountable. Even if it's not related to a vaccine reaction, we want to downplay everything. We want to be free from any culpability. Okay. Then it's used to identify trends of concern. And then it is also will be useful for our case investigation. Now, for example, based on the rates I've shown you, so when the Department of Health, for example, will have supplemental immunization campaigns, then we can estimate the number of minor, rare, severe reactions following the vaccination so we can be ready and we can respond to them. For example, if we're going to conduct measles vaccination for 1.5 million children, common minor AEFI that are very rarely reported will have these numbers of reactions among these children. And then for rare, more severe AEFI, which we hope will be reported, will include, for example, 508 cases of febrile seizures. So that's what Department of Health does. We anticipate everything. Because we cannot count on honest reporting or even from our passive reporting, then we should have estimated the number of reactions every time we have mass immunization. And then we compare this to the actual AEFI, and to tell you frankly, look, 6 non-serious. Exactly, practically it's not being reported. Okay. Next please. Now, there are examples of real safety issues that goes back to the previous century that involved tuberculosis and the inactivated polio cutter incident in 1955. we list here the true vaccine reactions that have been in recent years been scrutinized by several experts and studies and debunked consequently. Okay. We have here examples of unproven associations and public concerns like influenza vaccine and the Guillain-Barré syndrome. I did my own research how it happened that in the 70s, the Guillain-Barré syndrome was actually associated with influenza vaccine. During a press conference to announce the program of the United States to begin vaccinating millions of Americans against the swine flu, a reporter in a press conference asked one of the health providers issues on adverse events. But because at the time they were also looking at Guillain-Barré syndrome, it was miscommunicated to the media that Guillain-Barré syndrome followed the vaccination using the swine flu strain at that time. So even without evidence at that time, the CDC, because they accepted reports of Guillain-Barré, had actually to stop the vaccination, and it was called the swine flu fiasco. But what was not revealed after was that it was a miscommunication. So we have to emphasize this again and again. And as president of the Philippine Foundation for Vaccination, we emphasize that vaccination should only be conducted by trained and appropriately equipped staff. Okay. We provide training to the health staff. And now this raises a concern because after the elections, okay, there will be changes among the ranks in the local governments, and then we have to retrain them again. So the Department of Health has to spend every 3 years for retraining people. Okay. Then the contraindications and precautions should be known and followed by all vaccinators. There is an urgent need to do this, but surprisingly, even those among you in this room will have little or moderate amount of knowledge on the contraindications and precautions. And that is not to criticize you, but because vaccines are thought of that way. It's always safe to give. Okay, and so therefore the contraindications and precautions may escape your practice. Although the evidence will show that there is no evidence of harm, we should always be on the precautionary side. And although my colleagues will not agree that with my personal opinion, at the Department of Health, we make sure that events following immunization should be reported, analyzed as the facts begin to unfold. And I will show you why. So the key elements of the effective AEFI surveillance system, which we have now renamed immunization safety, because there is some concern with using the term adverse event following immunization. It tells you that something wrong is going to happen after an immunization. So we want to call this now immunization safety protocol. So we hope that there's going to be a rapid notification of basic information, and we're able to make an evaluation, respond to it, and then ensure appropriate outcome of the response, and then we educate. This is the history of vaccination, at least globally, and in fact here in the country. Where vaccine coverage has increased, it has shown a significant decrease in morbidity and mortality contributed from the protection against these diseases. But the loss of confidence actually results in outbreaks, including the anti-vaccine lobby groups. And of course, sometimes government is at fault. For example, in Japan, any report of adverse events for Japanese encephalitis, for example, they had to withdraw the vaccines and then they'll see outbreaks. And of course, when the confidence resumes, then we are on our way for eradication, and then we altogether stop the vaccination against that particular disease. So there are global initiatives, and one that is particularly interesting is the Brighton collaboration started in England, where Brighton is, in 2001. Okay. It aims to develop a globally accepted and implementable standardized case definitions. It's like this. Your fever may be different from hers, okay? May be different from theirs. And so therefore we cannot compare data. And so therefore it's very important that we count apples and oranges separately. It's also important that information should be shared. And we encourage you to look at the results of the Brighton collaboration. It's available in the internet. They have since defined up to 17 adverse events. Okay. So for example, when they discuss fever, what does it mean for the World Health Organization? So they gather a number of experts, and some of my colleagues here have participated in the Brighton collaboration. What does it mean in different countries? What does it mean in clinical trials? What does it mean for manufacturers? What does it mean for you? And so therefore, they would define fever. They would have definitions for fever. They will, for example, be specific as to how they will measure fever and in which site. And so therefore they come out with their first report with fever as an adverse event following immunization. We encourage you to read this article and the other articles published by the Brighton collaboration. So for immunization safety, we want to detect, report, investigate, and analyze, respond, then communicate. So this is the pathway, the Department of Health, as we subscribe to this pathway of how we will detect and respond to immunization safety concerns. To illustrate, we're going to share with you data from the measles cases in Magaldan in Pangasinan. Okay. We also refer you to the WHO aid memoir on AEFI investigation, so that this is the checklist for doing surveillance and response. Okay. In March 14, 2006, 4 hours following measles vaccination, 4 cases of apparent signs and symptoms of fever, vomiting, generalized redness were manifested. Okay, Magaldan is in Pangasinan. It's a first-class municipality with 30 barangays. And the the target population for FIC is 2,786. This is the timeline. Okay. The numbers here represent the interval between the previous event to the next event. For example, it took us 2 days before the cluster was reported from the rural health unit. And then it took another day before the regional office in Pangasinan was able to, in Region 1, was able to investigate. Because it's required further investigation, the National Epidemiology Center, which is in charge of the immunization safety surveillance, we received the report, then we sent a team, and already 19 days has elapsed. And then we make a conclusion 7 days later, when the Immunization Safety Board met, and that's over a month after the cluster was first detected. Okay? And the media would either find it several days later, a month later, and then it will have consequences but everything has been completed here. But the media reports would actually have significant impact in the local government. For example, there were life threats to the midwife. Okay. So we face challenges for efficient timelines in detection. Okay. So if you do not report immediately, can you imagine the domino effect and our failure to make an assessment and analysis of the data you're going to share with us? Okay. So the investigation looks simple. We ask about the patient, we ask about the vaccine and other drugs, we ask about other vaccines, we ask about immunization services. We actually observe them during their immunization days. We ask about cases in the unvaccinated. We establish a more specific case definition, we formulate a hypothesis, and then we collect specimens. Unlike those prescribed by the Brighton collaboration in an investigation, we craft our own case definition for the adverse event. For example, ask about the patient. For this particular case study, there were 4 immunized at the time. And there were 4 children, okay? They manifested as hypersensitivity reaction. There was no admission. 3 were admitted in the intensive care unit presenting with toxic shock syndrome, a systemic viral illness, and a septic shock syndrome, and 1 death. Okay? The autopsy of the child who died was cerebral edema, severe secondary to acute disseminated meningoencephalitis, probably viral in etiology. Siblings were not ill. Do we need other information? Okay. So at that morning, during the vaccination, 15 other children were given DPT, 14 were given OPV, 5 were given BCG. The 4 children given measles vaccine received from the same vial at the same site between 2:45 p.m. and 3 p.m., same lot number and expiry date. We should be that detailed. I'm telling you this so that when you encounter adverse event in your practice, you have to get the details. Okay? Use your Cory watches. Okay. Okay. Ask about other vaccines. Okay. How about the medical records and EPI documents? We have to review them. The immunization process is assessed, the ocular inspection. So therefore, it's hard work. It's teamwork, it's laborious, but it's the only way. And may I remind you of Finago's law of information. First one, the information we have is not what we want. The second one, the information we want is not what we need. The third one, the information we need is that which you cannot obtain. Okay. So we need this information, so we have to obtain them. Then we ask about cases in the unvaccinated. For example, the RITM identified 3 other regions allocated the same vaccine lot numbers. So because there were no reported similar event from time of receipt of A and B and no other reported AFFI within the region, and if we are certain with this, then we can make some interpretation and further conclusions. So we established a more specific case definition for this particular event. So who? So it's a child between 9 to 13 months who developed 3 or more of the following. This is the what, when, within the first 24 hours of measles vaccination on March 14, where. Okay. So this is separate from the Brighton collaboration case definitions because for surveillance and investigation purposes, we have to look at the evolving event. Then we formulate a hypothesis on the cause. WHO has this algorithm and you can use this in your practice. Okay. And for this particular event, it was traced to a programmatic error. Okay. Then we collected specimens. For example, we tested vials and diluent, and these were sent to a laboratory. And this showed growths from these samples, Staphylococcus aureus, and we were able also to recover bacillus in one unopened measles vials diluent. According to the BFAD, now FDA, specialized collection techniques are needed. Most likely, this was a contaminant. Okay. Now, the evidence was presented to the Immunization Safety Board. Okay, so there was a clustering of AAFI. There were no reported AAFI cases in other health facilities with the same lot of the vaccine. The diagnosis of infection ranged from abscess to toxic shock syndrome. The use of aspirating needle, leaving it pierced on the vial and placing back the vial in the mini cooler while waiting for the next child was a risk. The used vial was positive for Staphylococcus aureus. The vaccinator did not follow prescribed guidelines in the administration of vaccines. So the practical issues, even in your clinical practice, is that you should decide what should be investigated. For all intents and purposes, you need help. We are just a dial away. So get this number, 711-1001. It's easy to remember. I don't have to repeat. 711-1001. Okay. The black screen tells you that the presentation has ended. But I have a question. Are you ready for your H1N1 vaccine? Okay, we're not giving you any. Wala. Are you ready for your H1N1 vaccine? Okay, good luck.